Hello and welcome back to our bullshit. I don't have the mic again, so I'm sorry. Anyway, today we're gonna talk about stroke a little bit, and hopefully we do not end up in another diabetes scenario, but you know me, I like big topics and a lot of words, so let's go. In the United States, strokes are responsible for about 5% of all deaths and are the leading cause of disabilities. So as pathologies go, it's important to know what the fuck they are and how we treat them. So a stroke is defined as an acute neurological condition resulting from a disruption in cerebral perfusion, which is to say a stroke is a collection of symptoms that occur when you have brain damage due specifically to not getting enough blood to part of your noggin. So not enough blood means that the tissue becomes damaged and then dies. And depending on what tissue of the brain is affected, you can have very different symptoms. But I digress. We should start at the beginning. So you can have two different types of stroke. You can have ischemic and hemorrhagic strokes, right? Ischemic stroke is a cerebral infarction due to hypoperfusion, aka not enough blood getting somewhere because something is blocking the vessel, just kind of like in a myocardial infarction / heart attack. The other thing that can happen is a hemorrhagic stroke, and that's when an area of the brain doesn't get enough blood because a vessel has ruptured and is bleeding out. So like basically the road that the blood is on to get to the brain gets diverted and all the cars are like spilling out of a hole instead of driving down the road. Medical metaphors may not be my strongest suit. When it comes to hemorrhagic strokes, there are actually a couple of different things you can talk about because it's not just that the rupture of specific vessels in the brain can cause damage, but also you can have damage due to the pooling of blood. So there are a couple of different versions of these, right? We have intracerebral hemorrhages, which is bleeding within the brain parenchyma. And then we have subarachnoid hemorrhages, which is bleeding into the subarachnoid space. And then finally, we have interventricular hemorrhages, which is bleeding within the ventricles. And if you kind of don't understand that, then I implore you to Google some stuff about the different layers of the brain. And if that all doesn't make sense to you, don't worry about it. What you want to understand is that the brain is housed in the cranium under a couple of layers of connective tissue and padding. And bleeding in those layers can be just as damaging as bleeding internal to the brain because the pressure that will build up because of blood pooling will damage both the tissue and can cut off the blood supply. And all this shit can get confusing because a lot of people use just kind of subtly different wording on these things, and they can all be kind of referred to underneath the umbrella term of hemorrhagic stroke. Luckily, most strokes are ischemic, which is to say 85% of all strokes will be ischemic, and then 10% are intracerebral hemorrhages, and finally 5% are subarachnoid, which is basically saying 10% of those bleedings are bleeding within your actual brain, and 5% is you bleeding kind of around your brain. And the last thing we're going to talk about here is the transient ischemic attack, or the TIA. And that is a temporary focal cerebral ischemia that results in neurological deficits without acute infarction or permanent loss of function, usually defined as being less than 24 hours in length. And it's sometimes called a mini stroke because in a lot of ways, it's basically just a stroke with no staying power. The definition of TIA has changed and the duration of symptoms kind of has been de-emphasized. The important defining factor is the absence of infarction and that the fact that by definition, there is no permanent injury in a TIA. So great, TIAs are temporary, but also having a TIA is a pretty big risk factor for having an actual stroke. So all TIAs are treated as strokes until proven otherwise. So what are risk factors for stroke? Obviously, there's going to be a few differences between the two sort of three types. For ischemic stroke, it's age over 65, hypertension, which really these first two things are risk factors for a lot of stuff, diabetes mellitus, and if you want to know more about that, I direct you to the 4 videos I have on that topic already. Atrial fibrillation, because it can cause clots that travel up the carotid arteries and lodges in the brain, and then carotid artery stenosis, because clots will break off the carotids and lodge in the brain. For hemorrhagic stroke, the first two are the same, so age over 65 and hypertension. And then you have vasculitises because it can cause vessel weakness. Malignancies for the same reason, and finally ischemic stroke because of a thing called reperfusion injury, which we are going to talk about later. Then for your subarachnoid hemorrhages, those are usually actually caused because of a ruptured aneurysm. For the subarachnoid hemorrhages, this usually comes from a ruptured aneurysm. arteriovenous malformations, and trauma. So the real identifiable risk factors are hypertension, because that increases your risk of rupture, and tobacco, because smoking continues to be the worst for you. And then, of course, family history. And that's because certain congenital syndromes will lead to arteriovenous malformations or the formation of aneurysms. For both ischemic and hemorrhagic strokes, age is the most important non-modifiable risk factor, and arterial hypertension is the most important modifiable risk factor. So, we are back on our we fucking love ACE inhibitors vibes. So, fabulous. Now we know what strokes are and we know what the risk factors for them are. How do we diagnose and treat them? The bad news is stroke symptoms are actually going to look a little bit different depending on what part of the brain is affected, which makes sense. So depending on what vessel or what region of the brain is injured, the symptom set will look slightly different. And I really do want to talk about that specifically in more depth. So yes, this is not a one video topic again. So let's actually skip clinical signs and symptoms for now, and let's just talk about diagnostics and treatment. First things first, making your diagnosis of stroke quickly and correctly is extremely fucking important. Quickly, because the longer a region of the brain goes without oxygen, the more damage will occur and the less chance of reversibility. Correctly, because I just said one of these stroke types is ischemic, which is to say a clot is stopping the blood from getting where it needs to go, and the other is hemorrhagic, which is to say a bleed is stopping the blood from getting where it needs to go. To treat a bleed, we kind of want the body to clot, and to treat a clot, we kind of want the body to bleed. So fucking up which one is which when treating a patient will 100% absolutely make them worse and, even odds, kill them. Great. So now we're feeling the pressure. What do we actually do, Yara? I'm so glad you asked. So we're going to start at the beginning, as always. So you do your primary survey, and that is your ABCs, right? Airway, breathing, circulation. Because if you have a patient who no longer has an airway, you have bigger problems than the fact that they're having a stroke. You do want to do your clinical assessment and history. And this is important because part of this is literally determining, is your patient having a stroke, or did your patient have a stroke 2 years ago and still have some symptoms? You want to identify the risk factors for ischemic or hemorrhagic stroke because that's going to help you kind of have a reasonable suspicion in one direction or another. And one of those things that you're going to look for is actually the presence of carotid bruits, which is basically a sound that your carotids will make when they are not happy. You might want to use this time to identify the signs that indicate the affected vessel or the region of the brain that is being affected, but I haven't taught you how to do this yet, so don't worry about it. Finally, a super important part of this is you need to determine the onset of symptoms, which is to say the patient's last known normal. The time of stroke onset determines whether or not certain treatment options are available. Also, it's just generally a good idea to get timelines on your patients. If they say, oh yeah, I haven't been able to lift my arm in 3 years, I do not know what that accent was, I am sorry. Anyways, if they tell you, yeah, I haven't been able to lift my arm in 3 years, 1, we probably can't do anything about that now, and 2, that's very likely not why they're in your hospital today. All that is good and golden, but it will not tell you if a stroke is ischemic or hemorrhagic, although you can develop a reasonable suspicion in one direction or another. Still, it is very important in suspected stroke patients. Like, what is the most important thing? Motherfucking imaging. It's the future, y'all. Why guess about the brain when you can just fucking look at it? So our big first imaging modality is non-contrast head CT to evaluate for acute hemorrhage, and then you can maybe move on to diffusion-weighted MRI to determine acute ischemia, and then you can consider further neurovascular imaging types because, the future is now and we have a bunch of weird-ass equipment for it. Our first line image is non-contrast head CT, and why is that? Because it's good, and it can rule out intracranial hemorrhages, and you need to rule out hemorrhage for all of the other fucking imaging. So you do this first and you don't kill your patients, which that's the goal. Plus, if you've identified that the patient is not bleeding, you can administer thrombolytics at that stage. Okay, there are a couple of other things that you have to determine first. And not only does a non-contrast head CT allow for the detection of acute hemorrhages, it can also actually identify ischemic changes. It's just not as reliable as an early indicator. Basically, what a non-contrast head CT can do is it can identify ischemic changes 6 to 24 hours after it's occurred, which ideally we don't even let the stroke get to that stage. But if your patient wakes up with a deficit, for example, you might be able to see all that you need to see on a non-contrast head CT. So I know that I've said this a couple of times, but I truly cannot emphasize enough. Non-contrast. Non-contrast. If you have any suspicion that your patient might be bleeding into their brain, do not give them contrast. Okay, enough about that. What about our second imaging modality that I brought up? Diffusion-weighted MRIs. Diffusion-weighted MRIs are cool because they allow for the identification of ischemic changes significantly earlier than a CT. They can actually identify it within 3 to 30 minutes of onset, which awesome. It also actually allows for the detection of hyperacute hemorrhages, right? It's a very high acuity imaging modality. It is, however, more time consuming and more expensive than a non-contrast head CT, which is why we do the non-contrast CT first so that we can commence treatment in the shortest amount of time. Diffusion-weighted MRIs are super cool though, because they can actually evaluate the reversibility of ischemic injury. And then you have these things like perfusion-weighted imaging, which kind of visualizes the area of decreased perfusion and allows for the quantification of perfusion parameters, e.g. mean transit time, cerebral blood flow, and cerebral blood volume. And then you have perfusion-diffusion mismatch MRIs, and that allows for the identification of the penumbra. And the penumbra is just an area of potentially reversible brain tissue injury caused by hypoperfusion due to stroke. But it's also a cool word. Penumbra. Penumbra. Anyway, if you determine that it is an ischemic stroke, you may also do some neurovascular studies like a CT angiogram or a CTA. And that's cool because it allows you to identify the exact location of the deficit in most cases. And basically you use it when there's a super high index of suspicion for stroke, but you're not able to find ischemic changes on your non-contrast CT or your MRI. If you're having a little bit of trouble with that, that's fine. Don't worry about it. Just understand that your first line imaging modality for stroke treatment is the non-contrast head CT. And that is because it's pretty good and it's also very fast. And when it comes to stroke, we're kind of in a rush. Speaking of being in a rush, when you are rushing your patient off to that non-contrast CT, you are still going to want to grab some labs. One thing that you absolutely need to try and grab is a serum glucose. And that's because symptoms of hyperglycemic and hypoglycemic crises can resemble a stroke. So you have to have a serum glucose in most hospitals before you can commence any of these treatments. And it's an extremely fast test, so it should absolutely be completed prior to imaging, because if your patient is having a hypoglycemic attack, that's significantly more reversible, but it should be treated quickly. Also, like as a pro tip, like we don't want hypoglycemic attack patients just chilling in our CTs when we could fix them by giving them orange juice. Other stuff that is nice to have are going to be your complete blood count, your electrolytes, your coagulation panel, so your INR, your PTT, your urine drug screen for recreational substances like cocaine, a blood alcohol level, plus serum troponin. All hospitals and ambulance services will have their own stroke protocol, and they may require you to get different labs. But here is the thing. Laboratory studies should never, ever delay imaging for patients who are you suspecting are having an acute stroke. So grab your bloods, do it, but do it while you're hauling ass to a CT. Now, a lot of things are going to make you think that your patient is having a stroke, but they're not. And I'm just going to run through some differentials, and then we'll talk about treatments and complications. And I swear to God, this is only going to be 2 videos. I'm getting better. It's a process for all of us. For me, I think about stroke differentials by breaking them into a couple of different categories. And the categories are neurological, toxins, some ENT bullshit, infections, psychiatric, traumatic, and paraneoplastic syndromes or autoimmune disorders, which, now that I've said that, that's a lot. We're going to bust through this together. I'm here for you. You're here for me. Let's go. So we're going to start with neurologic, right? So your first thing that can be kind of confused for stroke is actually seizure, right? Some patients who are undergoing seizures will have something called a post-ictal paralysis, where they'll demonstrate neurological deficits post-seizure activity. Other things are going to be like brain tumors because of their mass effect, or migraine auras even, which fucking terrifying, I know. And then your last thing is the cerebral venous thrombosis, which is like, it's basically extremely similar to a stroke, but the actual problem is that blood can't leave your brain instead of blood not being able to get to your brain. Toxic metabolic syndromes that can be confused for strokes are going to be things like hyponatremia, hypoglycemia, diabetic ketoacidosis. So basically what I'm saying is keep your fucking electrolytes in check. Alcohol withdrawals, some types of drug intoxications like heroin or barbiturates, and then a thing called osmotic demyelination syndrome, which is its own fucking insane thing. Don't worry about it. ENT shenanigans, this is exclusively insane stuff. So I fucking, You're welcome to Google. I'm not worrying about it. Under your infectious pathologies, we have meningitis, encephalitis, meningoencephalitis, cerebral epidural abscess. So basically, anything that makes your brain inflamed might give you symptoms of stroke. You can also have progressive multifocal leukoencephalopathy, which can present with a very specific kind of leg weakness that looks like a stroke, and Lyme disease, because Lyme disease will give you some nerve palsies, which, again, that's kind of a symptom of stroke. There are also psychiatric considerations, so things like conversion disorder or even malingering. And just a quick reminder, malingering is a diagnosis of exclusion. And if you look at a stroke patient and your top differential is malingering, I will reach through this computer and fucking kick your ass. Some traumatic-based differentials are going to be things like a traumatic brain injury or a concussion, and all those fun bleeding things that I talked about that occur outside of your brain, like subdural hemorrhages and epidural hematomas and stuff like that. And then a thing called Brown-Séquard syndrome, which is when your spinal cord fucking splits in half. And that is an insane thing that is worth Googling, but do that on your own time. And finally, the last section, and also my favorite section of potential stroke differentials, are paraneoplastic syndromes or autoimmune disorders. So things like multiple sclerosis or Bell's palsy or Guillain-Barré syndrome can look like stroke. Anti-NMDA encephalitis, and also lung cancer, which is a very interesting thing because lung cancer can give you this paraneoplastic syndrome where it presents with myasthenia gravis like Lambert-Eaton. And I only bring that up because I personally find it super fucking cool. If you zoned out, now's your time to zone back in. Okay, so we're done with that insane fucking list. And what's important about that is just that a lot of things can look like stroke, but you need to have a high index of suspicion because it's always better to assume that something is a stroke and be wrong than miss a whole ass stroke. So when in doubt, get that non-contrast head CT. Great, okay, so, once you're in the scanner and you've determined that this is in fact a stroke, what do you do? Well, one, that absolutely 100% depends on your hospital's protocol, but whatever, let's go. Well, obviously, your treatment of your stroke is going to depend on what type of stroke it is. So I'm going to talk a little bit about stuff that you want to do for all stroke patients, and then we'll dive into specifics. So we're going to start with stabilization and monitoring, and some of this will make a little bit more sense when we talk about the symptoms of strokes in the other video, but I'm just going to say some things that you want to be keeping an eye on. So you want to maintain euvolemia, which is to say you want to keep their fluid levels balanced, and you will do this with fluid replacement if needed. You want to maintain a sufficient oxygen supply, and you should be considering intubation if the patient is showing signs of either increasing intracranial pressure, altered mental status, but you should also be evaluating these patients for things like dysphagia or other things that could potentially compromise their airway. Like I said before, if your patient isn't breathing, that's going to kill them faster than the stroke. You want to maintain euglycemia and you want to maintain normal thermia, which is just fancy medical nonsense for saying watch their sugars and make sure that their temperature stays in normal ranges. Stroke patients, depending on what's actually happening, can slide to either side of these scales, so you do need to be making sure that you're keeping an eye on it. You also want to maintain normal acid-base status and electrolyte repletion, right? Especially if you're giving fluid replacement, be mindful of the patient's electrolytes. I said it before, but I do think that it's worth reiterating. You need to be keeping an eye on these patients for signs of increased cranial pressure and also seizures, and seizures should be treated pharmacologically. The final thing is analgesia. Give these patients analgesia if you need them. We don't want patients to suffer, and stroke is not actually a contraindication for analgesia. I mean, obviously you want to be careful and you need to keep an eye on these patients and don't give them nitrates because that'll fuck up their ICP. But yeah, don't unnecessarily cause these patients to suffer. Just remember, stroke patients under no circumstances should be considered stable. Finally, but not any less importantly, is hypertension. Hypertension, it's bad. We don't like it. In ischemic patients, there's this thing called permissive hypertension, which is to say in ischemic stroke patients, we only treat hypertension when it becomes very severe. And that's going to be something like greater than 220 systolic or greater than 120 diastolic. And that's because in ischemic stroke, the perfusion of the penumbra depends on mean arterial pressure, right? It's dependent on hypertension. So we don't actually want to drop out their pressures and just make the problem worse. This is not true, obviously, for hemorrhagic strokes. We are going to treat blood pressure significantly more aggressively, although we're not actually aiming to bring those patients all the way back down to normal. You normally aim to bring them down to about a systolic of 140, 160, where a normal systolic would be 120. And our other obvious major difference is that in ischemic stroke, you're going to treat those patients with thrombolytics, if possible, which makes sense because we don't like clots that stop blood from getting to brain, so we destroy them. Right? The goal of the therapy is reperfusion therapy, which is to prevent further ischemia and prevent irreversible damage, and should be administered as soon as possible in eligible candidates. So basically, once you've ruled out hemorrhage as a cause, you're going to try to give IV thrombolytics. And IV thrombolytic therapy is just going to be some form of recombinant tissue plasminogen activator, which is going to be like alteplase or tenecteplase. The way that works is TPA, or tissue plasminogen activator, binds to fibrin in clots and converts plasminogen to plasmin, which breaks down the clot. Now, you can only do this if the initial onset of symptoms is within 4.5 hours. So make sure you have your last known normal down fucking pat. And all hospitals, of course, are a little bit different, but here are some reasons why you might not be able to give TPA. And that's going to be if the patient has any kind of active bleeding really anywhere. So either, hemorrhagic stroke or internal bleeding. If they have hypertension above 185/110, if the patient has either other symptoms of anticoagulation or a prolonged PTT or INR. And if you don't know what that means, I might do a video on the full blood count later. And if not, other people have. So look at that. If the patient has a low platelet count, or if the patient has hypo or hyperglycemia. You also cannot give TPA if the patient has ever had a hemorrhagic stroke, or if they've had a head trauma or an ischemic stroke in the last 3 months. And I'll talk a little bit more about why that is later. Also can't give it if they've had recent intracranial or interspinal surgery. And there are a couple of other more shenanigan reasons why you can't give it, like intracranial neoplasms, arteriovenous malformations, or aneurysms. TPA is an extremely good treatment for ischemic stroke, so find out if you can give it and then give it fast. Another treatment for ischemic stroke is actually interarterial thrombolysis. And this is usually going to be done with a thrombolytic like pro-urokinase, which also converts plasminogen to plasmin, but somehow doesn't do it the same way as TPA. I don't get it either. Don't worry about it. Indications for that are significantly more specific. You can use that specifically in middle cerebral arterial stroke patients who've had onset of symptoms in the last 6 hours, but are not eligible for TPA for some other reason. It's a pretty weird thing, but it's out there and now you know about it. Last thing in ischemic stroke is mechanical thrombectomy, which both sounds cool and actually is pretty cool. This is physical retrieval of the occluding thrombus, or the thing that's blocking the blood flow, via a catheter, which is usually inserted through the femoral artery. You do this when you have large proximal artery occlusion in anterior cerebral circulation, which is usually administered in addition to IV thrombolytic therapy. Now, the problem with that is it has to be reachable, right? So this isn't an option for a lot of strokes. And for these patients, you really want to get a CT angio because you have to be able to see it. You have to know where the clot is. I'm actually going to take a sidebar right here to talk about reperfusion injury because it's really important in the treatment of ischemic stroke specifically, and I said that I'd talk about it and I haven't yet. Reperfusion injury is actually a type of oxygen toxicity, and what happens is you reintroduce oxygen kind of suddenly to an area that was previously ischemic, so an area that just wasn't getting enough oxygen. And this usually occurs after about 6 hours. And what this actually does is it causes activation of endothelial cells that cause the generation of free radicals, and that creates damage. So sometimes in the treatment of ischemic stroke, you can get this reperfusion injury, and this will actually lead to a hemorrhagic stroke because the area has been weakened. And that's why a history of ischemic stroke is actually a contraindication for a lot of thrombolytic therapies because the risk of inducing a hemorrhage in those areas is so high. What happens if your patient does have an intracranial hemorrhage? What's the treatment there? Now, unfortunately, our treatment options are a little bit less robust. So We do want to do all that stuff that I talked about before, like maintaining euvolemia, and we want to treat blood pressure. But again, we don't want to treat blood pressure with any agent that might raise intracranial pressure, right? That's very bad, usually, and extremely bad in stroke patients. And then the other thing we're going to do for our hemorrhagic stroke patients is a thing called reverse anticoagulation. So hemostasis or anticoagulation therapy has to be carefully monitored and possibly adjusted, because you can cause deep vein thrombosis and like pulmonary embolisms, just like how coagulation therapies have to be carefully monitored because you can cause hemorrhages. In the way that we do reverse anticoagulation therapy, which for real, I'm just realizing we should absolutely call coagulation therapy, but I guess medicine hates us, is we do stuff like intravenous vitamin K, fresh frozen plasma or FFP, and then a prothrombin complex concentrate or PCC. And the other thing that you can give is recombinant factor 7A. Yeah, don't ask me about the coagulation cascade. I'm not going to talk about it. Go to Khan Academy. All of our other treatments for hemorrhagic stroke are surgical, and they can only be used in certain cases. Basically, we do surgery for hemorrhagic strokes when we have concerns about the blood building up and causing increased cranial pressure, or if we're having a concern that it's going to start clotting. And in those cases, we're going to do a craniotomy and do clot evacuation. And that's basically, we surgically remove a piece of your skull, which helps with the pressure and also lets us get in there. We do this when we have specific signs of brainstem injury or increased cranial pressure, if we're concerned about, brain herniation, brainstem compression, and then other things like obstructive hydrocephalus, which, like, if you don't know what that is, that's fine. Don't worry about it. Basically, for hemorrhagic stroke, our treatment options are reverse anticoagulation therapy and prayer, and they're about as effective as each other. Unfortunately, about 50% of patients with an intracranial hemorrhage will die within 30 days. So, our best actual treatment for stroke is proactive management of risk factors. Stopping your patients from having strokes keeps your patients alive. But okay, let's say you manage appropriate therapy on your stroke patient and they're doing well. There are also tons of complications associated with strokes. Some of these are medical, some of these are neurologicals, and I'm just going to hit you with the big ones, but there are others. Medical complications are things like cardiac dysfunction, so that's arrhythmias and myocardial infarctions, which is why it's so important to keep these patients on cardiac monitor. You can get aspiration pneumonia, and that's often due to like retained motor paralysis, difficulty swallowing. You can also develop deep vein thrombosis and pulmonary embolism, right? And other clotting problems. You have an increased risk of urinary tract infections and an increased risk of bleeding, specifically gastrointestinal bleeding. And then you do have a high risk of developing delirium and depression. You can also have neurological complications. So with all strokes, there's a risk of elevated intracranial pressure and brain herniation, like Cushing's triad. There's a risk of seizure. There's the risk of symptom. I can never say this on the first try, and we're just going to stick with it. Risk of syndrome of inappropriate secretion of antidiuretic hormone, or SIADH, which is its own thing. And then you can also have persistent neurological defects, right? Hemiparesis, aphasia, and prolonged disability. A lot of those things are the things that we just kind of think of when we think of stroke patients. Then there are some other stuff. So you can get this thing called central post-stroke pain, and it's in less than 10% of all stroke patients, and it can occur with thalamic lesions. And this is basically unilateral, so one-sided facial pain and or extremity pain that's associated with a previous stroke. You can also have contralateral or ipsilateral initial paresthesia and then have that followed with this neuropathic pain. You can just have patients who've suffered stroke can just have neuropathic pain. So I remind you, with these patients, consider analgesia. This is a painful thing. And then with ischemic stroke, you can have this thing that is called hemorrhagic transformation, which is the occurrence of a hemorrhage in the same region as previous ischemia, right? And this can occur in approximately 5 to 40% of cases. Yes, I looked up that percentage. No, that's not a helpful range of percentages, but it usually happens within 1 to 2 days of the ischemic event. You can also develop vascular dementia. And then finally, with hemorrhagic stroke, you can have recurrent hemorrhages or interventricular hemorrhages or hydrocephalus. That's all bad, but you can also get vasospasm, which typically occurs within 5 to 7 days after a subarachnoid hemorrhage, and that can actually cause an ischemic stroke. So, stroke, it's a risk factor for stroke. Okay, I think that was far more than enough for today, and I love you all. So next time we'll talk about clinical signs by vessel or location, or maybe we'll talk about forensics. I could be a true crime podcast. You don't know me. Until next time.